Hi, this is Mark Struthers. In today's discussion we are going to look at occupational exposure to ionizing radiation and emphasize the fact that the use of low-dose radiation in diagnostic imaging, if done appropriately, poses almost no danger to patients and occupational workers. On the other hand, exposure to high-dose radiation such as that used in cancer treatment and radiation therapy, the patients are at risk as we are using radiation to destroy tissue. This is why occupational workers in radiation therapy and oncology have strict safety protocols and procedures preventing them from being in proximity to high-dose radiation exposures. With the advent of digital imaging, radiation exposure for occupational users in X-ray has decreased. Here are some key points. Dose optimization. Digital radiography allows for better dose optimization, meaning that radiographers can achieve high-quality images with lower radiation doses. ALARA Principle. Radiographers adhere to the as low as reasonably achievable ALARA Principle, which aims to keep occupational radiation doses as low as possible. Personal protective strategies. The use of scatter shields in digital imaging has significantly reduced radiation doses to operators. For example, doses to the operator's hands and eyes can be reduced by up to 85% with the use of scatter shields. Minimizing repetitions. Digital imaging reduces the need for repeat examinations, which in turn lowers the cumulative radiation exposure for both patients and healthcare workers. The specific dose limits for occupational workers in medical imaging in the USA are set by various regulatory bodies, including OSHA and the NRC. Here are the key limits. Whole body dose. The annual limit for the whole body is 5 rems, 0.05 sieverts. Lens of the eye. The annual limit for the lens of the eye is 15 rems, 0.15 sieverts. Skin and extremities. The annual shallow dose equivalent limit for the skin of the whole body or any extremity is 50 rems, 0.5 sieverts. Dose limits for minors. The annual occupational dose limits for minors are 10% of the annual dose limits specified for adult workers. Pregnant workers. The dose limit for the embryo/fetus of a declared pregnant worker is 0.5 rem, 5 msv, during the entire pregnancy. These limits are designed to protect workers from the harmful effects of ionizing radiation by setting maximum exposure levels. Employers are required to monitor and ensure that these limits are not exceeded. Wearing a 0.5 mm lead equivalent apron can significantly reduce exposure to scatter radiation. Specifically, a lead equivalent apron or lead equivalent apron with this thickness can stop approximately 99.9% of X-rays at 75 kVp and 75% of X-rays at 100 kVp. At 1 meter from the patient, the scatter radiation is about 0.1% of the intensity of the primary X-ray beam. Therefore, with the protection of a 0.5 mm lead apron, the exposure to scatter radiation would be minimal. One remarkably interesting material is lead. Lead is used as a material to block the X-rays penetrating through, i.e., shielding. That is why lead is used for shielding, because in comparison with most materials much less lead is needed to stop the X-rays. Another fact that we wanted to note here is that fat is less dense than water, e.g., oil floats in water, and for that reason it has a lower X-ray attenuation. Other important materials of interest in the body are water and muscle. Muscles have a little bit higher X-ray attenuation than water. The amount of scatter radiation emitted by a patient is a small fraction of the direct X-ray exposure they receive. Typically, the scatter radiation at 1 meter from the patient is about 0.1% of the primary X-ray beam's intensity. This means that most of the radiation is absorbed by the patient or passes through them, with only a small percentage being scattered. Take-home points. Even water is highly attenuating. Typically 10% or less of the primary beam will make it through the patient. To increase the penetration, the X-ray energy should be increased. High Z atomic number materials like bone are more attenuating than water and have incredibly significant increase in attenuation for lower X-ray energies. Very dense high-Z materials like lead stop X-rays much better than common materials in the body. The percentage of radiation that penetrates the human body during a diagnostic X-ray can vary based on several factors, including the energy of the X-ray beam, the body part being imaged, and the patient's size. For low-dose diagnostic X-rays, a sizable portion of the radiation is absorbed by the body, while a smaller percentage penetrates through. For example, in a typical chest X-ray, about 90% of the X-ray photons are absorbed or scattered, and approximately 10% penetrate through the body. This is like the absorption rate for water. Radiation exposure risk. A general rule of thumb is that the amount of scatter radiation at 1 meter from the side of the patient will be approximately 0.1% of the intensity of the primary X-ray beam. So, if 10% of the radiation used in an exposure is emitted by the patient, the scatter radiation intercepted by PPE at 1 meter from the patient would be around 0.1% of that emitted radiation. When performing fluoroscopy procedures, it is crucial to follow specific guidelines to ensure the safety of medical staff. Here are some key recommendations. Lead aprons. Wear a lead apron that provides at least 0.25 mm lead equivalents on the back and with overlapping 0.25 mm on the front, totaling 0.5 mm, to protect against scatter radiation. Thyroid collars. Use thyroid collars to protect the thyroid gland, which is extremely sensitive to radiation. Lead glasses. Wear lead glasses to protect your eyes from scatter radiation. Protective shields. Utilize protective shields, such as mounted shields or ceiling suspended screens, to provide additional protection. Hand protection. Keep hands out of the primary beam unless unavoidable for clinical reasons. If necessary, use lead-leaded gloves. Distance and positioning. Maintain as much distance as possible from the X-ray source and patient. Position yourself behind protective barriers whenever feasible. International standards, IAEA, radiation protection of medical staff in interventional procedures. The average occupational dose of radiation exposure received during a typical interventional radiology procedure can vary depending on the specific role and the protective measures in place. Here are some general estimates. Physicians, the annual mean effective dose is approximately 1.50 msv. Nurses, the annual mean effective dose is around 0.55 msv. Radiologic technologists, the annual mean effective dose is about 0.48 msv. According to the NRC, the risk associated with radiation exposure of less than 100 millisieverts, MSV, is considered to be exceptionally low. Below this threshold, an increase in risk has not been definitively shown to exist. However, by scaling the risk at higher doses down to lower doses, it has been estimated that 10 MSV of radiation exposure could increase the lifetime risk of an adult dying of cancer by about 0.05%. In 2024, the position on occupational doses of ionizing radiation less than 1 sievert, SV, remains focused on minimizing exposure and adhering to the principle of ALARA, as low as reasonably achievable. This principle emphasizes that even small doses of radiation should be kept as low as possible, considering economic and social factors. The current regulatory limits for occupational exposure are significantly lower than 1 sievert. For instance, the annual dose limit for radiation workers is typically set at 50 millisieverts, MSV, per year, with additional constraints on specific organs and tissues. Thank you for your time and attention. Please subscribe to the channel to receive more informative discussions and presentations.